Well, hello, everyone, and welcome to the concept overview for alterations in cardiovascular function 2. Now, we've already talked a little bit about the heart in terms of the beta-1 receptors, but we need to talk about some other concepts in cardiac physiology. All right, this term we've talked about, systole versus diastole, but now when we are looking at heart failure and other cardiac conditions, we are really focusing on heart function and the cardiac cycle rather than worrying so much about systolic and diastolic blood pressure. So again, just a reminder, there are two phases of the cardiac cycle. Systole is when the ventricles are stimulated to contract and generate pumping the blood, and diastole is when the ventricles relax and fill. And both phases of the cardiac cycle are really important. Here are some terms. These are some new terms that we use when we're talking about heart function. So these are physiological parameters. The first one is called stroke volume. So if you imagine here on the left, when the ventricle is contracting during systole, it is going to eject a certain volume of blood. If I could stand there under the aorta with a bucket and measure the amount of blood that the ventricle pumped forward, that would be the stroke volume. A stroke of the heart generates a volume, okay? So here on this picture, which you have, I was indicating that the blood that gets pumped out during one systolic contraction generates our stroke volume. Now, the stroke volume can vary from beat to beat. So we try to average the cardiac function over time. And so what we do is we have a parameter that we call the cardiac output. And the cardiac output is measured in liters per minute. And you can calculate it pretty easily. You take the stroke volume in liters or milliliters and times it by the heart rate, how many beats per minute the heart is beating. So, unfortunately, we often don't have the stroke volume. So in most cases, as we will in this class, we will be talking about cardiac output in a more theoretical or abstract way. So if cardiac output goes up, it means the heart is pumping more blood. And if the cardiac output goes down, the heart is pumping less blood. And that's really good how we're going to use it. But you should know this equation. Very simple. There's another way that we can measure cardiac function, and the reason why we often use the ejection fraction instead of cardiac output is that cardiac output can vary based on the size of the heart. So if you have a big guy, he's going to have a big heart, and you have maybe a smaller female, maybe an 80-year-old petite woman, she's going to have a much smaller heart, okay? So in that case, it's hard to come up with normals for cardiac output. It really has to be based on body size and heart size. So what we tend to do is talk about the ejection fraction. And so this concept is a little bit more complex, but once you get it, it's pretty easy to understand. So when the heart relaxes and fills, so it's filling during diastole, and at the end of diastole, there's a certain volume of blood in that ventricle. We call that volume of blood the end diastolic volume, abbreviated as EDV, okay? Now, the heart then contracts and pumps the blood forward, and that is our stroke volume, okay? So if we take the stroke volume and divide it by the end diastolic volume, we get the percentage of blood that the ventricle moves forward, the ejection fraction. You can ignore the RV here. It technically stands for right ventricle, well, residual volume, but we won't talk about that term right now. We'll talk about that more when we get into the patho class, okay? All right, so ejection fraction is going to be an important parameter. All right. Okay, then the last thing that we're going to talk about is workload. Your heart is working a lot all the time. And this workload measures things that, basically how hard the heart is working. So just very simply, if heart rate goes up, the ventricle is going to have to beat much faster. That's going to consume more oxygen. That's an increase in workload, okay? But there are some other things that determine myocardial workload. And that's important because sometimes the heart is overloaded. So its workload is too high. And then that's where we start to see heart failure. So we are going to talk about two major components of myocardial workload. And we're going to be focusing on the ventricles because they're the ones that are working the hardest. The first parameter is called preload, and the second one is called afterload. So think pre, after, okay? It's going to have something to do with before and after the heart. By definition, the preload is the pressure that is generated in the ventricle at the end of diastole. So let's go back to our heart that is filling. So here we are, ventricle filling, filling, filling during diastole. And when it's maximally full at the end of diastole, just about to contract, we talked about the end diastolic volume, but that volume of blood has a pressure, the end diastolic pressure. And if we could measure it, if we could put a little pressure sensor in it, we could measure the end diastolic pressure. That pressure, that end diastolic pressure, is also known as the preload. Think about it for a second. It's filling, filling, filling. It's loading the heart. And usually during diastole, the heart fills, but it also dilates. Remember, the heart stretches out. And then according to Frank Starling's law, the more it stretches, the more force it generates. Okay? So the preload is pressurizing the ventricles, getting it to stretch a little bit so that Frank Starling's law can kick in and get it to contract. Okay? So preload. And I labeled it in the ventricles because that is where preload occurs and builds up. So when you think about preload as a clinical nurse, you need to be thinking about preload as a workload measure or factor that is primarily dependent on blood volume. So if blood volume goes up, that means there's more volume returning to the heart. It dilates the ventricles more and packs more volume in there, and preload goes up, okay? So we don't worry so much about low preload unless a patient is so dehydrated, the heart's not getting enough volume. But increased preload is an important part of our pathophysiology of heart failure and other problems. So there are some factors that would increase right ventricular preload and left ventricular preload together. And those have to do basically with fluid overload. So it could be renal failure with fluid retention that causes fluid overload. But anything else, too much IV fluids, kidney failure is a very common one, but any patient who has any kind of fluid overload, they would have an increase in preload on the heart. Heart may be able to compensate, or it may be too much. And we'll see what happens when it's too much. So the other parameter is called afterload. So when you think about preload and afterload, you need to kind of separate them out. So we're going to forget about preload because that loaded the heart as the ventricles were about to contract. But now we need to recognize that there is a pressure, and that pressure generates resistance to the movement of blood through the arteries. Okay, so what we define as the afterload is really the resistance to the ejection of blood out of the ventricle during systole. So think about this: when that left ventricle is contracting, the aorta has blood in it, right? It's not empty. And the vessels beyond the aorta can vasoconstrict and vasodilate, okay? There's blood in it, and the ventricle is going to have to push the blood forward. That pressure that it has to work against to get the blood out into the aorta, that is afterload, okay? So when we think about afterload clinically, one of the things that really has a very profound effect on afterload is what I was talking about before, vascular resistance, which really correlates to blood pressure. And so if there is a lot of vasoconstriction in the arteries and vascular resistance goes up, then afterload goes up. It's very hard for the ventricles to pump the blood forward. The ventricles have to work really hard. One thing to keep in mind with afterload is that we usually have to separate right ventricular afterload as being determined by the pressures and resistance in the pulmonary arteries, and then left ventricular afterload as being the pressures and resistance developed in the systemic arteries. So it's very unusual that we would talk about just general afterload on the heart. It's usually left ventricular afterload versus right ventricular afterload because the ventricles can be affected differently. So what I like to do when I'm kind of trying to summarize preload versus afterload is I like to draw a line at the valve between the vessel and the ventricle. So you could draw one on the right side as well too. I just drew it on the left for simplicity. So preload will build up in the ventricle, and that's volume dependent. Afterload will be developing in the arteries, and that's more based or related to blood pressure. Okay. And the heart has to contract against both of them. It has to contract against more blood. If there's more blood and fluid overload in the ventricle, that increases workload. And if blood pressure is really high, that makes it really hard for the ventricle to pump the blood forward. All right, so we have a couple questions just to make sure you're feeling really confident about this. Let me go through these. So the first question is, which of the following statements is the best definition of ventricular preload? So A is the volume of blood ejected from the ventricle with each systolic contraction. B, the percentage of blood ejected from the ventricle. C, the pressure generated in the ventricle at the end of diastole. And D, the force of contraction of the ventricle. So which one of these terms best correlates to preload? Now you should be able to go through these things and say, okay, well, this is that term that we learned, and this is this term that we learned, okay? So the answer here is C. A, can you recognize what that is? Volume of blood ejected by the ventricle with each contraction. That's stroke volume. And B, the percentage of blood ejected from the ventricle. That's ejection fraction. And there's no other term for the force of contraction of the ventricle. It is what it is. It's the force of contraction. Okay, so here's another question. This is about afterload. So which of the following conditions could cause an increase in left ventricular afterload? So A is dehydration, B is tachycardia, C is myocardial ischemia, and D is hypertension. All right, so if you put D, you would be correct. Remember from our discussion of hypertension, a lot of cases are caused by vasoconstriction, but either way, high pressures in the arteries is going to increase left ventricular afterload. Okay, we can't get pulmonary hypertension, but that would cause an increase in right ventricular afterload. Dehydration, that won't affect afterload very dramatically, and if it does, it will drop blood pressure and cause a decrease in afterload. But what dehydration will primarily do is decrease preload. Tachycardia doesn't affect preload or afterload. It's an independent workload parameter. If the heart rate goes up, the ventricle is contracting faster, using up more ATP, and increasing its oxygen consumption. Now, C is an important one. I always put it in there because I want you to remember the difference between oxygen supply and oxygen demand. So myocardial ischemia caused usually by coronary artery disease will decrease oxygen supply to the ventricles, okay? All these other workload parameters, preload, increased preload, increased afterload, and tachycardia, those will all increase myocardial workload. That's demand, okay? So just giving the heart less oxygen doesn't affect the workload, okay? If we have a high workload and myocardial ischemia, we're going to see some problems because you have a heart that now is needing more oxygen, but we're giving it less oxygen. Bad news. That's how we end up in heart failure. All right, well, you are absolutely ready to tackle our section on left and right ventricular failure. So we'll see you then.